Attention, all nurse practitioners and NP students. Are you tired of feeling the disconnect between clinical rotations and didactic teaching? Say hello to Success NP's clinical booklet guides.
As NPs ourselves, we know how valuable it is to have a resource that helps bridge the gap between clinical and class. So we created the digital resource to do just that. Our clinical booklets cover 5 major NP tracks: psych, adult, peds, family, and women's health. Success NPs wants to create tools and provide support NPs need to thrive in their careers.
So why wait? Check out our Success NP Etsy shop, linked in the show notes, for our digital guides and other digital clinical resources. Hi, Success NP. Your host here, Sandra Pagenta. And today we are joined by Heather Wilson. She is an RN and a former bedside nurse turned entrepreneur, which you know that we love here on the podcast. In 2000, she began her nursing career working on a cardiovascular surgical unit. And while she was there, she did what we always talk about on the podcast. She saw a gap. There was a lack of proper routine foot care services available for the aging population. And as she began to want to fill the gap, which I also love, she set out to create a nursing company to fill that void. And in 2011, she began providing care for seniors for foot care services that they deserved through her company, Everyday Divinity. She has also been creating a Foot and Nail Institute sister company in 2021, where she realized that other nurses wanted to learn about how she created her business. So she launched that to help other nurse practitioners and nurses create their own foot care businesses. And she's also, Heather, I don't know how you've done it, created a third business around helping other professions develop their own businesses, creating their own niches, things of that nature. She's a third business called Heather Wilson RN. And that's where she actually gets into the nitty gritty of building businesses. Welcome, Heather, to the podcast. I'm so happy to have you on. You are a spitfire ball of energy.
Thank you. It is such a pleasure to be here. Thank you for having me.
Yeah. So let's dive in. And I know you've been featured on NBC, CBS, Fox News. So you are just a depth of knowledge on all these subjects we're going to be talking about. But let's get started about your nursing journey and what drew you to the foot.
So, what actually kind of happened was it wasn't something that I set out to do. And I think that's true with a lot of entrepreneurs. We kind of find that things fall in our lap that we're kind of like, that's peculiar. And I did not set out to become a foot care nurse. I actually was going to work in the bedside. I was going to be, the nurse at the hospital. My whole family was medical. So that was kind of the path that I had always seen as a nursing profession. You go, you work in the hospital, that's where you retire. What happened for me was I started to see some changes in the healthcare system that I started to question. And I remember thinking to myself, is this the way it's going to be? Is this what I
What were
have to
you
do?
seeing?
Just changes that were taking place. I think when the computer system rolled out for charting, I think that put a wall between us and the patient. And I think that was by design, honestly. I think that they did that on purpose to separate us. And I think that the relationship between the patient and the healthcare provider is a sacred one and one that we really love and pride ourselves on as nurses. And so when that wall went up, I felt that with the patients that were our frequent flyers that would come to our unit, they would say things like, "Oh, we can't talk anymore. We can't have that bond. We can't have that communication anymore. No, I don't have time for that. I have to check boxes now." And so that's one of the things I really hated. And so the autonomy of nursing was being stripped away. I wasn't allowed to make decisions. I had to do everything guided by these boxes and what they said. And science and nursing and healthcare is not black and white, obviously. We have to read between the lines a lot of times. And that was being stripped away. We weren't allowed to do that. So I started to really question, could I do this as a healthcare provider until I retired? And the question became no. And what I noticed was when I would go into work, I was a charge nurse. And when I would go into work, I would have such high hopes for the day. And when I would get to my car at the end of the day, I would sit in the garage and just cry because I felt like my soul was just being crushed. And I thought, this isn't what I'm here to do. This isn't what nursing is about. So I really started to question and look around at what else I could do. True fashion, you start looking at other units, you start looking outside of the hospital. And then I got to a point where I kind of got to a place where I started to kind of just pray on it, look around. What is the purpose with all of this? I have this nursing license. I worked really hard for it. I don't want to give it up, but what can I do with it? And what I kept noticing was there was this process in the hospital system where patients would come in, they would have these open heart surgeries, and they would ask for somebody to cut their toenails. And a lot of times, what we were supposed to do was we were supposed to consult podiatry to come in and provide that service. Over the years, what was happening was it got harder and harder to have them come in and provide that service. So it would take sometimes 6, 7 consults before they would come in.
Was
So
that
I
just
got
because they were so busy?
this was
Why was
happening
that?
because I finally asked the podiatrist one night because he came in and I said, I was the mouthy charge nurse. I said, why does it take 7 consults now to get you here? Because it used to not. And he goes, because honestly, what's happened is I make no money on this, Heather. He goes, reimbursement rates are horrible. I make no money trimming toenails. And then he said, I didn't go to school to cut toenails. I went to school to learn surgeries. And it hit me. And I thought, okay, if you're telling me that in a hospital, what is going on out in the community with these patients? And I said, where do I send them? Because they're going to ask me. So what's the solution? And he said, I don't know. He goes, we tell them to go to a salon. I knew that wasn't the solution because at that point, we were already getting an influx of patients that were coming in from salon visits that were having lower extremity infections. And we had a lady at that time that was getting her lower extremity, she was having a transmetatarsal amputation done because of osteomyelitis. I said, really? That's what you tell them? And he said, yeah. And I said, you need to go talk to the lady in 8 because she has osteomyelitis. We're going to do an amputation on her because she went to a salon. Do you want to go tell her to go to a salon? And he was like, Heather, I don't understand why you guys can't do this. All the stuff you do on this unit, you can't cut toenails. And I said, we're not allowed to. And he said, who says? And I said, the hospital. Find it. Find it for me, and I will get you a bottle of wine. I will get you your favorite, most expensive bottle of wine if you find that written up for me. I found it written up in the institutional policy of the hospital. However, when I went deeper, I couldn't find it in my board of nursing anywhere. Couldn't find anything about foot care. And what I've learned over the years is I think that what happened with it is years ago, I think that we did not want to step on, no pun intended, but step on the toes of the podiatry industry by providing that service. And what ended up happening was insurance restrictions cut that down, and they basically have whittled it down to so many restrictions that they're making $5, $10 on the service, if that, and they're fighting for that money. And they're like, I ain't going to do it anymore. So now they're not doing it. So we've left the senior demographic out there in a marketplace that does not have any access to this. And what happens as we age is we can't provide the service for ourselves. We get older, we can't bend, we have hip issues, back issues, knee issues, vision and dexterity issues, arthritis. We can't provide the service for ourselves. It's not something we really notice until we are in our elder years. And then we're like, I can't do it anymore. So they're calling these podiatrists and they're like, yeah, we're not doing that. Or they're going to salons and are getting infections, And so what I was seeing at the hospital was all of this. And I saw this huge gap in the healthcare system. And I thought, okay, I could do this. So I researched, I looked into it, and I realized that the majority of boards of nursing don't have regulations created around this because it falls under an ADL for nursing to provide the service as an RN.
Oh, okay. So just like in activities of daily living. This
Yeah.
isn't actually like,
Yeah.
okay,
We
like
don't
within
even
our
have
scope. This isn't
regulations
like
created.
okay.
So I was like, I'm
Yeah.
just going to, jump off this cliff and I'll seek forgiveness versus permission because they're not going to give me permission. I reached out to the board. They didn't call me back. They didn't email, nothing. I thought, I'm doing it. So I launched the business. And then what I found was the business was successful and it was something that took off. It grew bigger than what I could keep up with. And then I had nurses asking, how do I do this in my community? I had seniors calling me from all over the nation asking, where do I find a foot care nurse in my area? And so it was just made sense to me at that point to create the Foot and Nail Institute to basically help meet the needs of both of those demographics, the nurses that wanted out of the bedside, that wanted to duplicate that income, and also help these senior patients who needed access to safe care. And so that's kind of how those two things became the evolution of the Foot and Nail Institute and where we are today.
That is insane. So I love this story. This is just the way that you articulate it is just, you can just see it. I can just see it getting built. It's so incredible. And what does it look like? Like, what did you structure your clinic and your business to be about? Because it just seems like, what do you have, like a chair and like a place for someone to put their, like an ottoman and you just sit there and clip toenails? Are we doing, you know, assessments as a foot specialist nurse. Like, what was it that you were building at your business to create a value add for patients instead of going to the nail salon and maybe getting your nails done? No, you're getting this other package with this nurse.
So it was interesting because when I first launched, I was doing ABI testing, I was doing monofilament testing, I was checking for neuropathy, I was checking for a lot of things. I was giving these results to the patients to take to their provider, especially the ABI result, because I had a vascular background. So I know how to do all that.
What is ABI?
Ankle brachial index. And it's basically to check the blood flow of going to the feet and, the claudication and all of that. So I was giving those results to it. So there's certain results that you can give. Now they do Doppler flow studies and very much a lot more things than they do back in the day. But when I started back then, you could do ABI testing, you could get a value. And if that value fell between a certain area, you knew they had impeding blood flow restriction and everything. So I would give those results to the patients. They take them to the doctor, and the doctors didn't want anything to do with it. It was funny because I was like, really? They were like, yeah, they said, are you going to have surgery? Are you going to have this done? Are you going to have that done? And they threw your results in the trash because I said, no, I'm not going to have surgery. And I think there's a disconnect here because a lot of these community doctors are so afraid of getting involved in learning about vascularization of the leg and the lower extremity. And we have to understand that if you have a bad heart, you most likely have bad legs because your vessels in the heart, are the same with the legs. So I think that, there's something that to be said about we have a lack of education taking place in society because these doctors think that all of these surgeries are huge, big cut down surgeries like they were 15 years ago. We have so evolved in that space with catheterizations and being able to do a lot of opening up in surgical techniques that
Like
a lot of these
stenting and stuff?
doctors, sorry?
Yeah, like stenting, we don't have to
Yes.
do full-on
Yes.
procedures, right? We can stent, we can,
Exactly.
yeah, do
Yes.
minimally invasive surgery that can actually maybe improve some of your symptoms and, stop worsening damage. It just seems very odd that they were just like, "If you're not gonna do this huge surgery, we're not gonna do anything. We don't care
They don't
about
wanna get
these
involved.
results."
They got 15
That's
minutes to see a
really
patient, and
scary.
they don't wanna have that conversation. It was, mind-blowing to me because I was like, "Okay, all right, I'm not gonna do it anymore." So I quit doing it. And basically what I found was the majority of the patients that were coming to my clinics were basically looking for those foot care services. They wanted the toenails trimmed. If they had corns and calluses, they wanted those dealt with, and that was it. I would say that honestly is probably 70% of what I see. If I see something that is further that needs a wound evaluation or needs to be a vascular intervention, I will then tell them, go and see your physician. This is what I'm recommending. And basically, I write it on a note and give it to them. Like, here's what I need you to take that and talk to your doctor about. I've had a couple patients that they've come back to me and said that they didn't want anything to do with that. And I'm like, okay, you know what? Go and seek out a specialist in that field. And so then I kind of gear them towards the cardiac specialists who do vascular surgical stuff and vascular interventionalists and such. And that's kind of how I've dealt with it. But there is definitely room for education in that space. And that's why we have vascular centers now. And that's definitely where a lot of these people need to go. And so I hope that that grows and the knowledge grows among people because I think that people are so used to large surgical procedures. They don't even know what we've done in advancements in medicine that do stand. And these are overnight procedures often. They're not a big deal. And they would help people extensively with mobility and pain and neuropathy. A lot of these things would be helped if we would just have an intervention at that time. But a lot of times they don't want to take that on.
Yeah. So being a nurse and starting your own practice, I'm a nurse practitioner. We have a focus on NPs on this podcast. And so do you see nurse practitioners breaking into this space? Because is there something that could we do some type of, non-invasive procedures in this? I don't know if you're seeing any of this in this niche that you're in, but is there a room for this role to grow outside of what it is that you were doing that a nurse practitioner could crack into? Or, yeah, I think that's the question.
A few NPs who have come through the program. And it's interesting because what I have found with the NPs who have started the program is that the quality of lifestyle that they have done here has replaced that of the hospital system. And so many of them have kind of backed away from the hospital system, and this has replaced what they want to do because it's quality of life. You set your own schedule, you set your own days. You don't work holidays, weekends. If the weather's bad, we don't come out in the weather. We don't have clinic. I mean, we just cancel the clinic. It's a totally different avenue as far as what they're doing out here. A lot of them start out, they're doing it on the side. And the next thing you know, they're kind of like, you know what? This is better than what I'm doing. And with the healthcare restrictions being so restrictive and tight, I think that they're fed up with that. And they're fed up with the insurance route. And because this is a private pay service, they are kind of at the point where they're like, I don't want to be restricted as I am in the healthcare setting. So there definitely is, if people are interested in going into the vascular assessment route, I would say partner up and work with a vascular interventionalist and be able to recognize those patients when they come in. You see the brawny skin, you see the rope veins, you see all of that. And that is stuff that needs to be dealt with. And oftentimes it's not until we have an emergency on a Friday night at the ER. But if we could have those early interventions to assess the lower extremities and get patients to, the right physician, I think that would help. But it's just right now, the way healthcare is, we are limited on time and availability to be that resource to patients, unfortunately. And
Yeah.
that's the route healthcare is. We're locked on time and we have to see so many patients in a day. And that's what a lot of the nurses who've come through this program are like, I am not locked into that when I have my own clinic and I have my own patient load. I can do it on my time, my hours, and basically provide the service. And so that's kind of what draws them in and provides them a better lifestyle. And that's what they love.
Yeah, because what you just described is another gap. Like, and that was what I was noticing as you were talking, was that there's a gap between what we're doing, taking care of routine health care for the feet, cutting, trimming, taking care of people's feet, assessing, knowing when something looks concerning to where we wouldn't put them at risk for infection, because we understand with our nursing background how to administer care, keep things clean, keep an eye on things, assess, manage, continue to monitor and assess. Those are the things that we do as a nurse that easily translates into skills that you can do to help with routine foot care. And then as you were talking, I thought, here's another gap, that now there's a gap between getting those patients into vascular and can the nurse practitioner fill that gap? And that's what you're saying, potentially. Like, why not? Why can't a nurse practitioner fill that gap and kind of create a minimal invasive? Hey, listen, I couldn't get this done with my minimally invasive techniques, whichever those are in vascular, which I don't know, but fill that gap. And then now you could refer them. And so now you're a stepping stone to them getting quicker, better care that as outside of this realm. And so you could start here and continue to grow as your, you know, education and your scope increases as a nurse practitioner. It's very interesting. So one of the things that I like to do and provide to nurse practitioners is clinical assessment tools, maybe some things that we should be looking out for as NPs in practice when we look at people's feet. Because again, the feet are a gateway. I mean, I know we kind of ignore them. They're in shoes and socks. Patients come and see us and we don't really look at them, but we know that they're not just for helping us walk, that they are an overall health indicator for other diseases and other foot and ankle conditions that could be going on. And so I thought, since you have just such a depth of knowledge, that maybe we could talk about some things that MPs should be looking at whenever they start, you know, they're seeing a patient in clinic.
I think one of the things that I would like for to understand about this is I think there's a gap within looking at the feet itself. I think that a lot of us believe that the podiatry industry is taking care of these patients' feet, especially our diabetic population, and that is not the case. A lot of my patients haven't seen a physician, and a physician hasn't seen their feet in years. And I think that a lot of times the primary care physician thinks the podiatrist is doing it, and the podiatrist thinks the primary care physician is doing it. So this is where we have a gap within that system in itself. And oftentimes the foot care nurse is the only person who is seeing these patients' feet. And a lot of times, things that begin simple enough as fungal nails can turn into secondary infections that need to be addressed. So that's something that we can look at. Fungus happens. It does, occur as you get older. A lot of it can be genetic. A lot of it is hard to get rid of, and there are medications for it, but it can be hard on the liver. And so oftentimes when these patients are older, you can't put those patients on those type of medications. So, one of the things that we have to do is we just have to monitor and make sure that these patients aren't developing secondary infections. The other thing we want to look at is macerated web spaces in between the toes. We need to look in there and see, are they having any type of yeast, any type of athlete's feet? Things that start off simple enough, that's a lot of times where the wounds end up becoming something because they've been ignored. Shoes. We don't realize that as we get older, our feet get longer and wider, especially with childbirth and with age, because the tendons and the ligaments stretch out and elongate and the feet get wider. So what happens is patients are wearing the wrong size shoes. We're not even wearing the right size shoes. It's crazy to me because you ask patients, this is one of the things that we do when we do health fairs. We measure feet. And you can buy, I forget what it's called, the thing that measures the feet. You can buy that on Amazon and measure feet. And it's crazy to see how many people are wearing the wrong size shoes because they think that their feet are the same size as what they were in high school. So we're not even wearing the proper
Yeah.
shoes often when we get older. So just those types of simple things are things that we can help these patients with. And I'd say, the other thing too, feet isn't for everyone. And I completely get it. And I've had nurses that are like, feet is just not my thing. I don't want to do it. I don't want to take the socks off. We all know about, taking the socks off and the cloud of snow. We know. So what I say in that case is there are foot care nurses in every state in this country. And so this is why it's important. And I've seen this shift already. We've had a lot of NPs partner up with foot care nurses who have formed the relationship with them. And they basically are telling their patients, there's a foot care nurse, call her, she'll see you, and she can kind of help you guide down that path. So we've formed a lot of those relationships and bonds because we're all nurses at the end of the day. And so nurses are definitely looking for those resources. We've had a lot of community resource nurses and NPs reach out to us and contact us and say, can we have your information? Can we have your contact information to give to our patients? Because we don't want to do it, but we know you're out here and you can do it. And that's how we found a lot of our patients was just through those types of avenues. So if you don't want to do it yourself, that's fine. Consult or, work with a foot care nurse that's local to your area and they will definitely do it for you. But it's funny to find the people who are wearing shoes that are 2 sizes too small. And just those in itself hampers your mobility, opens you up for wounds, opens you up for the bone reconstructing of the feet and stuff as they age because everything's moving and shuffling around as you get older. And the next thing you have hammer toes, you've got, bunions happening now, you have a lot of things occurring. And it's basically because they don't have space in their shoes.
That is mind blowing. And as you were talking, I'm seriously like, I'm going to go get my feet checked because I just had 2 children. So I'm
Yeah.
sure my little Shrek feet have gotten, big or swollen or wide or whatever. So yeah, you definitely, and they don't tell women that. They don't tell pregnant women that like your feet are going to be different. They say they swell, but you think they go back. Like, of course, hopefully everything goes back the way it was after the baby. But you're so right that maybe it doesn't. Maybe you just got bigger feet and you're just different now. And that is just absolutely mind blowing. And I
Well,
did
you
not know
think
that. And
about it
it's just,
with
yeah,
how we've become like as society, we order everything online. We no longer go into the
yeah.
store and have people measuring our feet like we did. I mean, years ago. We
No,
now are
yeah,
like online. And when's the last time anybody's measured your feet at a store? It doesn't
yeah.
happen. Yeah.
No, but to touch on what you just said, you are right. There is kind of a stigma with feet, and it is this, I don't know what it is. I've kind of Googled it before I was going to chat with you because I wanted to know what like something about feet. It's just got like a humility aspect to it. It has this kind of, I don't know, like, I won't touch your feet. Like, I don't know. There's just this like, because we walk on them, they're like, they get a bad rap to a certain extent. But I think that what you're describing and a nurse that takes care of your feet has a lot to do with, I don't know. I just think about, I'm a Christian and I make it very clear that I am, but it's just got such a service and a love that's in feet care that I just feel like if you are wired that way, what a great caring aspect you could have for patients' lives. And I just kind of see that echoed in, when Jesus washed the feet of his disciples. And it makes me just think of like, just, I don't know, just the amount of love that I think nurses just naturally have. It just exudes out of them. And to get in the space and help people with their feet when they can't reach it or you're getting older, there's that whole process. And then for a nurse to get in the pit with you and just be like, no, that's okay. I'll take care of your feet. It's like, oh, like that bond has got to be so incredible. And I can really see it being rewarding
Yes.
just from
It fills the
that
soul. It really
interaction.
does. It's the most
Yeah.
rewarding thing,
Yeah.
and these patients are so appreciative to it, and that's what nurses who have gone through our program, they're like, "I'm just waiting for where's the bad stuff?" Because I'm now at the patient. I'm with the patient. I'm at the patient level. I'm connecting with them, and we're at a soul level, and it is a soul to soul connection.
Hey, NP student or NP graduate, yes, you ever freeze when it's time to present your patient case to your preceptor? Suddenly, you're rambling about the thing that happened, and the preceptor gives you a puzzled look. Well, winging it is no longer an option. Introducing the Case Presentation Guide, a free step by step framework made by experienced NPs for NP students and new grads. Learn what to say and what to skip, how to keep it concise, and how to sound like you actually know what you're doing. Nail your assessments with clarity. Move through the history and plan like a pro. The best part of the case presentation module is that it's free. FREE, free 99. So make sure to click the link in the show notes. This is all a part of our course launching January of 2026 called the Success NP Academy. It is your step-by-step guide to launching your NP career with confidence. We'll help you go from overwhelmed to organized with lessons on charting, case presentation, job hunting, and actually feeling ready for day one in practice. Because let's be honest, they taught you how to diagnose pneumonia, not how to negotiate a contract or figure out malpractice insurance. You've got the degree. We'll help you get the direction. Now, let's get back to the conversation.
Yes, for sure.
Yes. And so that was one of the things I was processing, was just like, no, it's like an underdog field that you could actually create such a connection. And I think that that actually helps with burnout too, because when we are working as nurses and nurse practitioners and we're caring for people and we don't feel a level of connection to our patients, but also that we're making a difference. And when you get into the pit with somebody and they're vulnerable and you take your shoes off and you're with someone, I can just imagine how that space automatically opens up and gratefulness just fills it. I don't know why. I just have that. I can just see that. And I was just thinking about that as I was looking up what you do and kind of going through my own biases as I was looking at like, what do I want to do for care? And then it was just like, no, like that is such a beautiful space to practice in as a nurse. Like, don't sleep on it. Don't sleep on it because you might actually find that there's a depth there that you weren't finding when you were doing just regular med surge and getting that, barrage of hospital administration on you and not feeling like you can spend time with your patients. And then you're like you said, I never would have thought it would have been feet, you
I
know?
never would have thought, but it has healed so many of our nurses. And that's the beautiful side of it is when you build a business, you really are working on yourself. It's not only professional development, but it's also personal development. And so we've had a lot of nurses who have come through the program. They've built these successful businesses and they have healed the burnout. They have healed the wounds of what they endured at the bedside. And this is something that is just the most rewarding way to get back to the patient, get back to yourself, get back to nursing. And that's been a beautiful process to see how many people have risen up and are thriving using that nursing license again, who were like, I'm done, I'm burned out, I'm going to go and work at Walmart and do something completely different. This is something that has given them the opportunity to get back to the patient and basically caring for the patient in that vulnerable space. And it's been a wonderful transition for a lot of nurses. So it's been very, very, very much a blessing for a lot of us.
Yeah, I love that. And so to kind of close out this part of it, what are some things that a nurse practitioner in practice seeing? And this is for the nurse practitioner student or for the nurse, early budding nurse practitioner that's like, all right, I don't know what to look for in feet. I don't know. I went right through nursing school and into became an NP and I don't really know what I should be looking for. What are some things that they should be aware of and urgently refer either to a podiatrist or a vascular surgeon? And maybe just touch on those things. I know you're an expert in them and then we'll just close out kind of clinical pearl stuff.
Would say look and see the history. Do they have a cardiac history? If they have a cardiac history, then I would obviously include the feet in the next assessment with them because typically if they do have the bad heart, they have the bad feet. I would look at are they a diabetic? Are they well managed as a diabetic? A lot of these patients are not. Why are they not? Is it a financial issue that they can't afford medication? Is it, patients who are like, I don't need that? We've had resistance. A lot of times people are pre-diabetic and they hang on that and they're a full diabetic and they still want to say, I'm pre-diabetic. No, you're not, John. Your hemoglobin A1C is, through the roof. No, you're not. So look into that. I would also say the peripheral vascular disease issues, look into that. A lot of times, patients don't even understand. They just call it bad circulation. Why is it bad circulation? Look at neuropathy. What is it? I think that neuropathy has become something that we are just so often not treating because we've just accepted it. Oh, it's neuropathy. It's a battle that we're not going to win. And yeah, we have the Neura and we have the Lyrica, we have the medications that we can put patients on. A lot of times these patients don't like those medications, so they're not taking them. And so I have to look at other issues of how we can treat that. And it's things such as magnesium lotion, amazing results with magnesium on patients who have neuropathy. That does work for patients, but
Like in a foot soak, like in a foot soak bath type thing, or like
there's
orally?
actually magnesium lotion that has helped a lot of patients we've seen in clinical practice with just basically applying it. It's magnesium lotion that you can purchase and you can basically just rub on your legs at the end of the night before you go to bed. It has helped with restless leg syndrome and has helped with neuropathy. And simple things like that. We need to look beyond the traditional roles because oftentimes these patients aren't going to take the medications because it makes them feel woozy. It makes them dizzy. They can't get up in the middle of the night to go to the bathroom and they're on Lasix also. And so those are the types of questions we just have to have the conversation with the patients. If we would get back to having conversations with the patient, we would find out so much. And as somebody who sits in front of the patients for 30 minutes, you learn a lot from your patient, what they're doing and what they're not doing. We're so quick to pull the computer in and say, okay, you're on this, 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 this. And they're shaking their head going, yeah, yeah, yep. They're not. A lot of times they're not. And they're not having those conversations with you because they know that you don't have the time and they feel like they're a burden at that point. And so we have to get rid of that. But we have to get back to caring for these patients and have the conversations about all of this, about all of the patient, not just what they're there for that day. And so that's kind of one of the things that I hope that changes in the healthcare sector one day, because that's the way it used to be. And if we can get back to that, we can learn a lot of how we can help these patients, and pivot them into the right specialist to help them further. And so that's kind of one of the things I'm hoping
Yeah.
happens.
That's a really good tip. Those are all really good tips. The questions that I kind of floated to the top as you were talking was how I'm trying to kind of establish it. How do you treat patients without the computer in a world now that you could only, I guess, because you're you don't have to kind of abide by the rules in order to get reimbursement. So you don't have to be glued to the computer. But how do you chart, or or are you all on paper? What is it that you're doing so that you can kind of bring down that wall and really kind of connect to patients?
So basically, what I started out doing was I had paper charting in the beginning. And what happened with that was my charting became so big, I was lugging it around. So it was like, I was taking it from facility to facility, assisted livings. I was going to these different places and I was carrying these charts with me. And so obviously, that's not the safest route because you can't be driving around with a bunch of charts in your car. So I transitioned over to online charting. And what I do is basically I do a lot of my charting prior to them coming in. So when I'm doing my reminder calls with them, a lot of times I do a little bit of a pre-charting with them, get their information. And then when they would come into the patient's clinic, when they would come into my clinic, what I would do then is just basically go through the highlights of what I needed to know. I don't need to know every medication that you're on because I'm not going to get involved in that. I need to know if you're diabetic. I need to know if you're on blood thinners. I don't need to know about every surgery you've had. That's not going to affect what I'm going to do for you today. And so I basically condensed it down. So I'm not spending 20 minutes going through your history and what you've done with your life as far as medicine and surgeries and all that. Condensed it down from what my purpose was, which was basically provide the foot care service. And that was it. So I did that. And that way it could put me back to the patient. And then my charting is very simplified. And basically, when I'm done with the service, I can go through a chart really quickly and I'm on to the next patient. I don't spend, 40 minutes charting on a patient. I just don't. And that's one of the things that's happened in healthcare is we have to cover our butts so much that we spend so much time charting. And who are we charting for? We're charting for the insurance company. We're not charting for the patient. We're not charting for the health of the patient. We're charting to appease insurance and appease the hospital system so we can maintain magnet status. That was one of the things that came down when I saw the changes coming. It was like everything is for, you know, Press Ganey scores and magnet status. And it's like we've lost sight of what we're supposed to really be doing here because we've given our control over to somebody else. As a private
Yeah.
provider, I
No,
don't have to do
I
that. I can structure my business accordingly that provides a safe clinical practice, but I'm not under the guise of insurance and the hospital and all the rules and regulations and such. I don't have to do it that way. I can do it the way, the old school way, the way we used to take care of patients.
yeah. And as nurse practitioners, that's a huge part of our job is charting, right? Because now we're charting like physicians, and now we have this legality part that we've got to cover. I hear what you're saying. There's also all this other charting and stuff that we have to do to meet these metrics, but also nurse practitioners have this added malpractice concern, right? And so we're charting to protect ourselves and all the different things. So it's just something that I was thinking about. How do we solve that problem of connecting with people when, as NPs, we've got all this charting that was weighing on us? But it's nice to hear that as you move into more of an autonomous role, you get to kind of set up what that charting looks like, and you can do a level of that before, see the patient, be aware. Now there's so many AI things as well that chart while you're speaking and while you're seeing patients. That's actually what I use in practice. It's made such a difference in the way that I think, because that's another thing that when you're so focused in on the charting during during the visit with the patient, I actually don't find that I think as much as I would if I just put the charting aside and focus in on what the patients are saying. So I think those are definitely huge clinical pearls for any new NP or, budding nurse to be thinking about when starting off in their career. So if you had to give three must-know foot care pearls for all nurse practitioners, what would they be? What would it be? I feel like you've touched on a lot of them. So even if it's not three, it's one big overarching pearl that would actually work here for a nurse practitioner that you're like, keep this in the back of your mind as you move through practice.
Say, talk with the patients. We have to get back to talking with these patients. We really do. We have to get to a level of humility. I think that we have become a society that we pride ourselves behind a lot of things, such as titles. I think that people, especially now, you see influencers crossing over, medical people that are becoming influencers, and people are seeing that. And we're doing some things for the wrong reasons. And I think that we need to get back to sitting with the patient and caring. We have to become caring individuals again. And we have become burdened by the restrictions that are laid on us. And so I think that the people have gone into healthcare. Some people I'm finding have gone into healthcare for the wrong reasons. And they're realizing that once they get out here and they're like, and I started seeing this at the bedside. People were coming out of nursing school and they're like, well, we weren't taught that. I'm not going to do that. They wanted to show up, wear the fig scrubs and I'm like, "That's not nursing. It's not nursing. Like, we're gonna get in here, we're gonna get
Come
dirty,
on.
and this is what happens." And they were like, "Oh, no, we weren't taught that. I'm not gonna do that." And it's like, we have got to get back to caring for these patients. And that's one of the things that, I have found that even when I take my son to a physician, or we go to myself when I've gone to physicians, the physicians that I relate the best with are the ones that have that conversation, that are not rushed, hurried. You're just a number. They see you, we have this dialogue. Those are the best providers. And that is what we have to get back to. We have to get back to some way of being able to provide care to these patients one on one, listening to the patient and listening to their concerns. They feel like they're a burden to us often. And that's what I've heard time and time again from patients is, well, I didn't tell my doctor, he doesn't have time. He's busy. He was running late that day. These are the conversations that we're hearing in our clinics. I would say things like, oh, they started you on a new medication. You're not feeling well. Did you talk to whoever about? Oh, no, they don't have time for that. I don't want to talk about that. I actually had a lady go out on me in my foot care clinic, and I'm in a senior center basement doing foot care. And she's telling me about her blood pressure and how she started feeling strange after she started new blood pressure medicine. And I'm getting all the details on this. So then I start asking her questions. I was like, are you diabetic? I'm going through my head, like, and I have it in my chart over there, but I'm like thinking I'm like assessing in my head, like, what am I going to do? Because I know she's going. And so, I'm in a basement. I have nothing. I have no IVs. I have nothing to give. And so I'm going through, I'm like, are you allergic to anything? Nope, no, I'm not allergic to anything. And just slower and slower talk. Next thing you know, she's like, passes out. I take her off to the chair. Literally, I'm laying her on the floor of the senior center, and the activities director's walking by. I was like, need you to call 911, please. And she's like, okay. And I'm like, oh my gosh. And I knew what it was. She was on a new blood pressure medicine that bottomed her out. And I'm in my head, I'm like, I know what she needs a bolus. I don't have an IV, I don't have fluid. And so when the EMT got there, I'm like telling him all this, and he like, we're having this dialogue, and it stuck with me because in that conversation, when I asked her, "Did you tell them about this? Did you call them?" No, I just feel like I'm a burden to them. And that's a lot of what patients are feeling like anymore because they feel rushed. They don't understand, the pre check in emails, the texting, all this stuff. They're just beyond it, especially our older population. They don't understand. Confirm with this text message, do your pre op check in online. And we're overwhelming them. And, so they're just kind of checked out. So they're just like fill in the box, like, I'll go in and see him. I have to go do it, whatever. But they don't want to tell you guys. A lot of times they don't want to tell their doctors or the MPs what is really happening or what is really going on because they feel like that you don't have that time for them anymore. And so that is something I would say as a healthcare provider, we have to get better at providing that care and that time, that compassion to these patients.
Heather, what you just said, I think we've got to spend a couple more minutes on because I actually believe you've touched on why I think the current medical system is
Yes.
broken. It's not just the big companies that are forcing us to hit these metrics. It's because the individual people, and I don't know if it's related to COVID, I don't know what happened in healthcare for people to look at people and see that they're people. And when I was a nurse, we were taught
Yes.
empathy. I don't really know if empathy is the right thing. I don't know what it is, but looking at people and realizing the sacredness of who they are and what they represent in the journey of their lives. And nurses are one of the few
Yes.
professions that get in
Yes.
there and they journey with you. And when you're sick in the hospital, your nurse is by your bedside every single day. And what a unique opportunity we have as healthcare providers to step into those spaces and create a caring environment. It's what we do. It's what we are. And if we don't have that and we have that mentality that nursing looks like quote unquote the nursing influencer in a pair of, figs and like that's not it. Like that's actually not the core and the soul of what nursing is. It's caring. And I completely agree with you that that is the number one take home for nurses and nurse practitioners to hear in practice is get back to caring, get back to getting in the trenches. Don't be afraid to go and get your hands a little dirty because you're going to find that that's where the growth is. That's where the growth for you as a person is as a nurse. It's not in the Stanley Cup and, the different things that we bring to work. It's actually in the care of people. And to a certain extent, what I'm hearing from you is that owning your own business gives you an opportunity to go back to caring, gives you an opportunity to go back to caring because you're not boggled down by so many of the other things that make you not care because you got to go do all these other things. So I can't care about that because I got to go do all
Yes.
this. And what a freeing thing you offer with your institute and teaching other nurses to do this. And what a freeing thing you chose in your career, even though in the moment it felt scary, it felt less secure. But actually, what you were giving yourself was an opportunity to care for people, was an opportunity to actually care about people and to really make your career meaningful. I think it's so deep. I think it's so beautiful. Where can our listeners find your resources, training, mentorship in foot health as an NP or a nurse?
So they can find me online at footandnailinstitute.com. I'm on LinkedIn under Heather Wilson. I'm also on TikTok. I'm on TikTok more. I'm on Instagram and I'm on Facebook, but I love TikTok. That's my
Yeah.
place. So
So
I'm
your
on
jam.
TikTok as Heather
Yeah.
Wilson RN. And so I'm there. That's kind of where I spend most of my time. The platforms can get overwhelming, so I kind of gravitate towards the one that I like the best, and I like TikTok, so I'm a TikToker. And if you would have told me that years ago, I would have been like, "No way, I'm not gonna do that." But the algorithm
Yeah.
is so
Yeah.
good. It just
Yeah.
finds what you like. It finds your content that resonates with you. There's a huge and nurse talk is huge on there. So, I mean, like we just had a huge follow for follow thing going on with nurses and everybody was supporting one another. And It was just really wonderful to see. The sisterhood and the brotherhood of nursing and medical professions is alive. I can tell you that. That is definitely alive because watching that
Yeah.
support take place on the app a few weeks ago was amazing to see how everybody was supporting one another. So it still exists. We just need to get back to being able to provide that care and that love that we have in our souls for one another and be able to provide that for our patients. And that's kind of what hopefully we can get back to that.
Yeah, no, I agree. And all the different resources that you offer for nurses and nurse practitioners that are interested in this. And then your third business that you started, just helping people get businesses started in anything, I think is incredible and just shows the metamorphosis of how you went from a bedside nurse to now launching a third business to help other people launch businesses, mentorship, legacy type stuff that you're building. I just think it's so incredible. So, thank you for coming on. We do a rapid fire at the end of a podcast episode. Are you ready
Do
for
it.
rapid fire?
Yes.
All right, excellent. What's your favorite pizza topping?
Ooh, I love Greek pizza.
Oh, I hope you like pizza. Okay, you like
Yes.
Greek pizza. Okay, I was gonna say, but what if you didn't like pizza? Okay, luckily you like pizza. Okay, so Greek pizza. So you're like
Feta.
olives, feta cheese, artichoke.
No artichoke, but feta. I love feta and the
No, oh,
olives. Yes.
okay, feta. Okay. Okay, very cool. And then if you have a season, your favorite season out of the four, what's your favorite?
I'm going to have to say, gosh, anything but winter. I live in Ohio, so anything but winter. But winter, I honor winter because I think that's where you have the time and then you can kind of grow. And spring is the blooming and the rebirth. So I have to say spring.
Okay, spring. I like that. I like that. Let's see here. And then for the last one, the last rapid fire, we ask, what is your favorite dessert? This is my go-to. I'm a cheesecake girl. What is it? What are you?
It's pistachio ice cream with it's called a tarte frutu. And I had it in New York City. I had no idea what it was and I ordered it. It's pistachio ice cream with like chocolate outer shell that's hard and it covers the ice cream. It's like my favorite thing. And I had it in New York City and it was delicious. So I didn't even like pistachio ice cream or pistachios until then. And now I'm like pistachio everything. So that's my favorite. It's like a pistachio.
Love that. I actually like the color pistachio. Yeah, no, I like everything. It's like a minty, fun color. Yeah, I agree. Pistachios are good. All right. So, because this is the Success NP podcast, we want to know, Heather, how you define success for your life.
It's interesting. When I started out building a business, I thought success was going to be, making X amount of dollars. And one of the things that I've learned through mentoring and coaching nurses on their journey of business development is that success is defined individually by what fills your soul. And so for me, it was the ability to be home with my son after school, to not have to miss the hockey games, to be available, for friends, families, events, types of things. That was kind of what I defined success as being able to wake up in the morning and work out, have my coffee, not run out the door, fight through traffic to hit a certain metric as far as an income. And so one of the things that I realized over the years is you can have all the money, it's not going to make you happy. And so it's interesting when I have people that come into the program and, when they lead with how much am I going to make? I always say never lead with how much you're going to make. Lead with what am I going to be able to give? Because we are here to serve. And so when we do that, we get
Yeah.
back. And so one of the things that I have found is for success for me was just to be able to have a healthy body, a regulated nervous system, especially after leaving the bedside, being able to, sleep at night, sleep well, and be able to, give back to myself, my body, my soul, spiritually, physically, and emotionally. That is success for me. And so it's basically being able to live that type of a lifestyle versus the fight or flight that I lived at the bedside for so many years, not realizing that I was frying myself and I was burning out. And so now that I can kind of sit back and look at the different lanes of that, that's what I realized is this is success to me. And it has nothing to do with income, has nothing to do with how much money are you making. It has to do with, your soul and how did you live and how did you love while you were on this earth. That's what I decide.
Girl, that is
Yeah.
good. I'm going to say the first step towards success is taken when you refuse to be captive. When you refuse to be captive to the environment in which you were first put and find yourself. Mark Kane. And I love that. I love that if you're a nurse that finds themselves in one situation, does not mean that you have to stay there. And success is the first step taken when you refuse to be captive to that environment. And I talk about that all the time on the podcast. That's essentially what you're talking about now. Just don't, if you're not getting enough sleep at your job, don't be captive. Don't refuse to be captive to that. Go change your environment. If you're unhappy, you don't feel like you're connecting with your patients, you feel that wall going up when the, EMR curtain goes up and now we're all captive to that. Change it. And that could be success for you. I love that. Love what you just said. Thank you so much for your time, Heather. Thank you for your energy. And thank you for everything you're doing for nurses, because by you breaking through the mold, by you breaking the ceiling, you make the way for other nurses to go behind you.
Thank you so much for having me. This is great. Thank you.
Be well, my friends. Thanks for tuning in to another episode of Success NP. We hope today's discussion has shed some light on the diverse career options or taught you how to improve your clinical practice as a nurse practitioner.
Remember, whether you're considering a specialization, pursuing advanced certifications, or exploring non-traditional roles, there's a wealth of opportunities out there waiting for you. Be sure to subscribe to the show so you don't miss an episode and leave us a 5-star review. It helps the podcast grow. The Success and Peace podcast is on the World Wide Web, YouTube, Instagram, Facebook, and X. So subscribe to our newsletter for updates on new podcast episodes and other information to help you on your own NP journey. You can always message us at successnpspodcast@gmail.com with any NP podcast episodes or topics you'd like us to discuss.
Until next time, take care. Stay curious and keep advancing your careers as a nurse practitioner. And just a friendly reminder, the information on this podcast is for educational purposes only. The information should not be used in substitute for professional care by a medical provider. The information on this podcast does not represent medical or professional advice or services.
Bye for now.